Julie. Welcome to this course on mental health issues in the elderly. I'd like to say that Julie bears a certain amount of responsibility because she originally suggested the topic as a good one for us, and we all agreed with her. So we're very pleased to have had good cooperation from the Department of Psychiatry at Shands, and they've had several senior fellows in adult psychiatry, or actually geriatric psychiatry, who volunteered to give talks. This morning's speaker is Stephanie Gerialde. Stephanie grew up in San Juan, Puerto Rico, and she went to college at the College of the Holy Cross in Worcester, Massachusetts, and then returned to Puerto Rico to attend medical school at, you'll forgive my pronunciation here, the Universidad Central del Caribe College of Medicine in Bayamón. And after she finished medical school, she came back to the U.S. for residency training in psychiatry. And she has completed regular residency, and she's had previous fellowships in child and adolescent psychiatry, and now she's interested in geriatric psychiatry. So she is a senior fellow in that program. Her interests are in advocacy of children and adolescent psychiatry, underserved populations, cultural psychiatry, and community-based psychiatry. So I'd say she's very socially oriented, as you can tell. So it's my pleasure to welcome Dr. Gerialde, who will talk to us on geriatric depression and bipolar disorder. Welcome, Dr. Gerialde.
Thank you so much for the introduction. Again, my name is Stephanie Gerialde. I'd also like to introduce my co-fellow, Dr. Ashley Lewis, who is here with me today. I'm going to be doing this presentation. However, Dr. Lewis will be presenting in a couple of weeks on anxiety disorders. And she's going to be my moral support today. So thank you so much for being here with me. And thank you all for allowing me the opportunity to do this presentation. So we're going to be talking about mood disorders in the elderly. Give me 1 second. If you guys have any issues where you can't see it, please let me know, and I can try to readjust the screen sharing. Are you able to see the current slide?
We are. It's perfect.
Wonderful. All right, so this is a brief outline on what we'll be talking about today. So we're going to do a brief introduction. We're going to learn to identify depression in the elderly, go over a little bit on the epidemiology, look at the clinical course of depression, prognosis, origins of depression, how we diagnose depression in the elderly, how we treat it. And we're going to briefly talk about some other mood disorders as well, specifically bipolar disorder. And then we'll go over a brief conclusion. So, in starting this topic, I want you to all think a little bit about what you think depression is. And if anyone would like to share what your thoughts are on depression, I would love to hear it. So any thoughts of what depression is? Well, it's okay if you don't want to share, but just think a little bit about it. I'm going to show you the portions of this video that I have here. So this is a TED educational video, and I think it's a very good presentation. So we'll start with this.
Depression is the leading cause of disability in the world. In the United States, close to 10% of adults struggle with depression. But because it's a mental illness, it can be a lot harder to understand than, say, high cholesterol. One major source of confusion is the difference between having depression and just feeling depressed. Almost everyone feels down from time to time. Getting a bad grade, losing a job, having an argument, even a rainy day can bring on feelings of sadness. Sometimes there's no trigger at all. It just pops up out of the blue. Then circumstances change, and those sad feelings disappear. Clinical depression is different. It's a medical disorder, and it won't go away just because you want it to. It lingers for at least 2 consecutive weeks and significantly interferes with one's ability to work, play, or love. Depression can have a lot of different symptoms: a low mood, loss of interest in things you'd normally enjoy, changes in appetite, feeling worthless or excessively guilty, sleeping either too much or too little, poor concentration, restlessness or slowness, loss of energy, or recurrent thoughts of suicide. If you have at least 5 of those symptoms, according to psychiatric guidelines, you qualify for a diagnosis of depression. And it's not just behavioral symptoms. Depression has physical manifestations inside the brain. First of all, there are changes that could be seen with the naked eye and X-ray vision.
All right, so I'm going to pause it there. But yeah, so this was just to give an idea of what depression is. And I think it's important to understand that depression does not necessarily look the same across different ages. So in children, for instance, I do have a background in child psychiatry. Children present with depression as feeling more irritable or having maybe some mental breakdowns or outbursts, I guess we could say. Adults might appear sad or down. Now, what do you think depression would look like in the elderly? Would anyone like to share your thoughts on what depression, what symptoms of depression we might see in the older patients or older population?
You kind of caught us off guard. We generally leave questions to the end, so now we're all...
Oh, I'm sorry. We could also leave it towards the end.
Let me see if there's anything on chat. I don't see anything here. Okay.
Well, we'll get into this in a second. But depression does look differently than what it would look like in an adult and then what it would look like in a child. So depression is the most common mood disorder in the late life population. Come in. Sorry, excuse me. Oh, sorry, excuse me. It's okay, no worries. So again, depression is the most common mood disorder in late life, but it's very often misdiagnosed or underdiagnosed in the elderly. And the reason for this is that depression in the elderly does not necessarily present as sadness as it does in younger patients. Depression in the elderly might look a lot more like feeling like you're not able to enjoy things, feeling indifference, lack of pleasure and stuff. There might be some somatic symptoms, for instance, pain or headaches or stomach aches. Like I've already said, there's a loss of interest. There could be sleep difficulties. There could be changes in appetite, thoughts of death. Anxiety is a very big symptom within depression in the elderly. And anxiety in younger patients can be part of depression, but it's not as frequently part of depression. There could be slowing in thoughts or in movements. And then some cognitive impairments such as confusion, inability to focus, misplacing things. So here we have it again, depression in the elderly versus younger adults. Again, the most important thing that I want to emphasize is that depressed mood might not be the primary symptom of depression in older patients, whereas in younger patients, is something that we frequently see, and it's much easier for us to diagnose depression in them because they come in feeling sad or down. But that might not be the case in our older population. So depression can be a symptom of many diagnoses. It can be part of major depressive disorder, which is what I am primarily focusing on in this presentation, but could also be part of a persistent depressive disorder, which was previously called dysthymia. It could be related to minor depression, which isn't a diagnosis that we typically use in our current DSM, which is our I guess our Bible in psychiatry, but it is something we previously used. Depression can be part of substance or medication-induced depressive disorders. It could be due to a medical condition. It could be related to bereavement, adjustment disorders, bipolar disorder. I am going to talk a little bit about bipolar disorder towards the end of our presentation. And then, of course, it could be part of neurocognitive disorders like Alzheimer's. In general, depression in the elderly, some of the more common risk factors are loss, grief, caregiver responsibilities. So taking care of someone who might have some neurocognitive disorder. And then, of course, the most important risk factor for depression in the elderly is medical illnesses. And we'll talk more about that as we move forward.
Dr. Garavalde,
Yeah.
pardon me, did you see there was a little chat that came up that said, could you define elderly?
Yeah. So in general, when we say elderly, we're saying above the age of 65. Yeah, so that's what we're referring to. And some portions, so the World Health Organization refers to elderly starting above the age of 60. But in the US, typically it's above 65. That was a wonderful question, so thank you. All right, so these are the symptoms of a major depressive disorder that are DSM-5, which is what we use in psychiatry as our guide to diagnose disorders. So this is not a picture of the DSM, but it's just a brief summary that I thought could be helpful for these purposes. But essentially, in a major depressive disorder, there has to be a period of about 2 weeks in which a person will feel that they have depressed mood or they're not as interested in things. Now, during those 2 week or that 2 week period of time, they'll also have other symptoms, or at least 4 of the following. So changes in weight or appetite, changes in sleep, changes in like agitation or moving a bit slower, feeling that they have low energy or fatigue, feeling worthless or feelings of guilt, like feeling things are your fault even though it might not be, thoughts of death or suicide, for instance, not wanting to be alive or wishing that you might not wake up in the morning. And so that's how we diagnose generally major depressive disorder. But again, depression in adults or in our elderly can look a little different than what the DSM actually says depression is. Now, persistent depressive disorder or dysthymia is often thought of a more chronic form of depression in which a patient will feel in general just sad and down for over 2 years. And then they might have a few other symptoms similar to major depressive disorder. For instance, they might have some appetite changes, some sleep changes, low energy, low self-esteem, poor concentration or difficulties making decisions, and then in general, just feeling hopeless. So again, signs of depression in the elderly. It's just really important to understand that depression in our elderly is not like depression that we observe in adults. There's a lot of loss of interest in activities that were previously enjoyable, loss of motivation, unexplained physical symptoms like headaches, stomach aches, feeling that you have no energy. And then there's some other signs that can also help us understand or help us think of depression. So not participating in your care, not attending your appointments or meeting with your friends, having low motivation, feeling that you can't take care of yourself, not really participating in self-care. And then some other things that, that are a little more subtle is if when we see people say things like, I just can't do this, I'm not needed, nobody needs me, I feel I'm in everyone's way. These are some symptoms or some things that will clue us into the fact that someone is depressed. So worldwide, depression, about 4% of the worldwide population has depression. In the United States, about 8.4% of all adults will have depression. But in the elderly, there's a lot of thoughts that the traditional diagnostic criteria we use to diagnose depression in adults might not represent what depression is like for the elderly. So although 4% of adults might have depression in the community, there's thoughts that perhaps there's a lot more individuals who do feel sad and down. Now, depression is frequently more observed in patients who are hospitalized, and this could be due to the fact that depression is strongly linked to having physical illnesses. So depression in the elderly who are hospitalized might have more symptoms, will increase. And then individuals who are in nursing homes will also have a higher percentage of depression. And this might be related to the loss of function. Now, when thinking of depression, I think it's important to know that depression is actually a chronic and recurrent illness. Typically, patients will experience episodes of depression, and that's when they come and seek help. Now, during a depressive episode, we might have a patient go into therapy, or they might start medications, and then their depressive symptoms might improve. However, untreated depression can improve on its own, but it just might take a little bit longer than it would if a patient is given medications. So we do want to intervene and have people receive help so that their depressive episodes can resolve a lot quicker. And then remembering that it's a chronic and recurrent illness, meaning that they will relapse and have other depressive episodes, is something that's important to understand as well. In the elderly, new depressive episodes tend to be very similar to depressive episodes that they may have had in their younger years. However, the frequency of depressive episodes increases. So they're having a lot more depressive episodes than what they previously did. And it might even resemble or might make someone think that they're just chronically depressed. So according to the National Institute of Mental Health, depression is most common in younger adults. However, there have been some studies that have looked at the lifelong trajectory of depression, and they have found that depression really has this U-shaped pattern that you can see here. So in this study in specific, they followed over 2,000 adults over 30 years and tracked their depressive symptoms or depressive episodes. Most depressive episodes did occur when they were in their younger adulthood, and then reduced during, their middle adulthood, and increased again in older or later ages. So I previously said that some cognitive symptoms can be part of depression. So sometimes when patients are depressed, they might feel more confused or not be able to make decisions as quickly or become more forgetful. Typically, when depression is when cognitive symptoms are part of depression, once we start treating the depression, those symptoms will improve. However, it is believed that having some cognitive symptoms during a depressive episode is a risk factor for later developing Alzheimer's or vascular dementia. It doesn't necessarily mean that that's the case, but it is something that we do like to think of. Now, it's also possible to have depression during a cognitive disorder. So someone who might have Alzheimer's disease or Lewy body dementia might experience depression during the course of their illness. In general, someone who has Alzheimer's disease and develops a depressive episode or depressive disorder, it tends to indicate that they might have more disability or perhaps lead to more physical aggression later on in the course of their dementia. It's not necessarily the case, but it is a risk factor. I previously said that depression is a chronic and recurrent illness, which means that typically depression that is not treated might eventually or improve on its own, or at least partially improve. But in cognitive disorders, patients who have Alzheimer's disease and develop symptoms of depression, they're more likely to, the depression is more likely to resolve on its own than it would in other forms of dementia. So medical problems and depression is an incredibly important topic, and these are frequently comorbid. So the link between depression and physical illness is bidirectional, so meaning that depression can lead to worsening, let's say, increased weight loss, but also, weight loss can lead to worsening depression. So it can go in both directions. Many chronic medical conditions are associated with depression, and these would be things like cardiovascular disease, diabetes, osteoporosis, hip fractures. It's very common to see depression in these chronic medical conditions. I think the most important risk factor for depression is the chronic medical condition that they might have. Now, it's unclear why there's a link between medical problems and depression, and there's many hypotheses. We don't have to go into that, but it's just something that, it's well studied, and we know that there is a risk or a link between the two. So if an elderly patient who was depressed and had no medical conditions, or comorbidities is another word we like to use, 70% of them will improve with just antidepressants, and 80% will improve with a combination of antidepressants and therapy. Now, there are some risk factors that do tell us that someone will not improve or only partially improve, and that would be the lack of social support or perceived lack of social support, and then of course functional limitations, so not being able to walk or being stuck in a wheelchair, or feeling that there is no social support. So these are some things that will impact the depression outcomes. So having good coping skills help depressive episodes improve a lot quicker, and also reduce the risk of having depression in the older age. Females tend to do better when they do struggle with depression than males. Extroverted personalities do also have improved outcome. And I believe that's because they tend to seek out social support. And then, of course, current or recent employment is also another thing that might have an improved outcome. And I believe that this could also be related to the fact that there is some social support in a job, and it's typically like a community. Major life events or serious medical illnesses, so not having those would lead to an improved outcome. And of course, the most important is the social support. I'm going to play this brief video.
Stay connected to combat loneliness and social isolation. Feeling lonely and being isolated are bad for your health. Loneliness and social isolation are associated with higher rates of depression, heart disease, and more. The good news is that you can help prevent and reduce the impact of social isolation and loneliness. However, it's important to know if you're at risk. Try to stay active and better connected if you live alone or can't leave your home. Feel alone or disconnected from others. Recently had a major loss or change. Are a caregiver. Or lack a sense of purpose. Here are some ideas for staying connected. Find an activity that you enjoy or learn something new. You might have fun and meet people with similar interests. Get moving. Exercise decreases stress, boosts your mood, and can increase your energy. Volunteer. You'll feel better by helping others. Stay in touch with family, friends, and neighbors in person, online, or by phone. And consider adopting a pet. Animals can be a source of comfort and may also lower stress and blood pressure. For more information about preventing loneliness and social isolation, visit www.nia.nih.gov.
Yeah, so I can't stress enough the importance of staying connected is, among the elderly. It's just a very important factor to help, fight depression. So now when we think of the origins of depression, there's a lot of things that could lead to depression. The way we typically like to think about these risk factors or these factors is by using the biopsychosocial model. So looking at biological factors, looking at psychological factors, and then of course looking at social factors. And then we put them together to kind of understand late life depression. When we're thinking about biological factors, this would be things like medical illnesses, high blood pressure, cardiovascular diseases. Oh, I'm so sorry. Oh gosh, where did it go? I'm so sorry. Why is this?
I think you can just X that.
Yeah, I tried.
Okay.
Okay, I'm so sorry about that.
That's okay.
All right. Oh, it's doing it again. All right. So biological factors, again, other medical conditions. Psychological factors, we're thinking about things like personality structure, coping skills, the way our lens of the world. Now, psychological factors don't necessarily cause depression, but they are contributing factors. And then of course, social support like loss, connectiveness with other people. This is a further list. I'm so sorry that this is connecting and reconnecting. I don't know.
Oh, you should. Okay.
So this is a list of a little bit further about the biopsychosocial factors. Let's do this. Okay. So yeah, this is a little bit more information about that, but we do not need to go into this list. So the way we diagnose depression, It's really based on his history, physical exam. We might do laboratory studies. I am so sorry. I don't know
We're not sure
why.
why it's trying to connect to this Epic.
This is so bizarre. Okay, sorry. So, why is it doing this? Maybe if I just log in, it will just
But
leave
if you
me.
log in, will it show like the list from today?
No, because I'm not gonna log into Epic. I'm just gonna log into the Shands thing. And then just X out. There we go. And maybe it will stop. So that's not working. Okay. So we might use some screening tools, and I'll show you an example of some screening tools we like to use because they are specific towards the geriatric population. When we're assessing someone's history, we want to know the current symptoms of depression that they might be experiencing. We want to know, if they've had any previous episodes of depression, if there's any like substance use. We want to know if there's family history of depression. We want to know if they've been on any medicines that have been effective, and just get an idea of like what interventions have been helpful in addressing previous depressive episodes. We do physical exams because sometimes depression can be symptoms of a neurological condition or a medical condition. So we do like to, complete a physical exam to, look into that as well. Laboratory studies is another important part of geriatric depression. So we like to look at thyroid, again, I'm so sorry, thyroid levels. We're looking to see if there's anemia, and to see if there's any vitamin deficiencies as well, such as low folate or B12. So these are some of the things that we do when we're diagnosing depression in the elderly. This is an example of a geriatric depressive scale. So these are two different scales. Again, it's just really important to understand that depression will look differently among our older individuals. In general, the lack of motivation, not necessarily feeling sad, but feeling that you're not able to enjoy things, feeling dissatisfied with your overall life would be things that these scales kind of try to gain some insight into. So the cool thing about, depression is an awful, disorder or illness, but the cool thing is that it can be treated. So it can be treated. In some cases, it can be treated with therapy alone. So we could use things like cognitive behavioral therapy, which was specifically designed to treat depression. And it's very effective for treating or addressing depression in the elderly. And of course, there's interpersonal therapy, which focuses on exploring and discussing relationships with other individuals. So that's another type of therapy we like to use for depression in the elderly. I'm so sorry why it's doing that. We do have some medicines that we do like to use. So the SSRIs are selective serotonin reuptake inhibitors. These would be medicines like Zoloft, Prozac, Celexa, Lexapro. These medicines have been well studied. And so it tends to be our first line for treatment of depression. And it tends to have less risk for cardiac side effects. And they overall tend to be better tolerated. In some cases, we do go to selective norepinephrine or serotonin and norepinephrine reuptake inhibitors. And these would be medicines like duloxetine, Effexor, and we use these more so as second line. There are some other medicines, but primarily we would be using our SSRIs and SNRIs. And very severe depression or depression in which there might be some self-neglect or depression that is associated with maybe some symptoms of psychosis, meaning like altered perception of reality. we might have to use ECT, which is our most effective form of therapy. ECT is, electroconvulsive therapy, and we induce a very controlled seizure in patients. And then TMS, or transmagnetic stimulation, is another form of therapy we use. It's not as effective as ECT, but this is an option that we use for patients who do not tolerate medications. And then, of course, family therapy is a very important aspect of treating depression in the elderly. We do need to, help educate family members on how to interact and how to be supportive towards our elderly population. All right. Bipolar disorders in the elderly. Bipolar disorder is another mood disorder where there can be an extreme difference between a depressive episode and a manic episode. So a manic episode is the extreme opposite of what depression is. So during a manic episode, a patient might feel that they're on top of the world, have a lot of energy, are starting a lot of new tasks, but not being able to complete them. Their thoughts might feel like they're racing and they're going really fast. They might feel like they have the power to do anything they want, and might even put themselves in risky situations. Now, in the elderly, when patients do have a manic episode, the manic episode might present with a bit of depressive symptoms as well. So that can occur as well. Now, new onset of bipolar disorder in the elderly is less common. Bipolar disorder is a disorder that tends to present in early adulthood. But some medical conditions such as strokes and maybe even treatment with some medications like steroids could lead to a manic episode. So it's the extreme opposite of a depressive episode. We do have treatments for it. We treat mania using mood stabilizers and in some cases antipsychotics. And we don't typically use antidepressants because that can exacerbate a manic episode in patients who have bipolar disorder. So here's some conclusions. So depression and sadness is not the same thing. Sadness can be something that we experience as a result of a life experience, and it tends to go away. Depression, we cannot make it easily go away on its own. Diagnosing depression in the elderly is often missed, and it's very common to miss this diagnosis because the depression looks very different. Depression can be treated. It's very important that you take care of your health, be active, sleep, address medical issues, stay connected with others, with your peers, with your families, and be supportive of those who may need help. Thank you. Is there any questions or anything that you would like me to discuss a little further on?
Yeah, we have a question in chat here. Let me see. I understand clinical depression. Please comment on suggestions for our ongoing COVID situation, which would be diagnosed as clinical depression, in addition to our ILR, which is extremely helpful. Thank you. Some of us are limited by immunocompromised conditions and Zoom in.
Yeah. So COVID has been an incredibly difficult situation for a lot of populations, but especially the elderly, where connection is so important. I do think we need to do a good, maybe a better job in finding other ways to stay connected with individuals, whether it's through having these kinds of conferences or having FaceTime or Zoom, Zoom meetings with other, people your same age or with your family. And finding hobbies that you can do that do not necessarily require face-to-face interactions. Do you have any other thoughts, Dr. Lewis?
I guess the only other thing that I would add is kind of just thinking outside of the box. I know one of the things that my family and I did for a birthday during the height of COVID, we had a like kind of murder mystery, and it was just on a Zoom call like this. So the person was an actor, and it was like there had several actors. So the whole service was set up, and just like finding different things like that. So us as a family, the whole family was on the call, and we were able to, with clues, figure out this murder mystery. So like in these kind of times, we can still spend time with each other, but we just kind of have to think outside of the box in different ways like that.
Any questions here in the Oak Room?
I would say that having watched the slides that dealing with the EPIC system is a major inducer, at least of anxiety.
I am so sorry for that. I don't know why this computer wants to share Epic so badly with all of you.
And now that it's done, it's not even doing it.
I know, I don't understand this.
You had one slide early on which suggested that you could medically or pharmaceutically treat depression. And I think it was showed that 25% of the people showed improvement. And then if you added psychological interaction with the therapist, it only raised it to 28%. And so the question is, what should be the major approach to treating depression?
Yeah, so I think there is no perfect way to treat depression. We try to tailor it to the individual. We do know that the combination of therapy and medications is the most effective form of treatment. I know that didn't lead to a big, percentage increase in the results, but it is a very aggressive form of treating depression, and I think it's an important combination. But again, we do tailor it, and we do like to think of like what, how severe the symptoms are, and kind of make decisions based on that.
Shirley, go ahead, unmute.
Hi, I wonder if you can realistically say getting older and being incapacitated and failing in so many ways doesn't philosophically have a depressive aspect to it that is realistic. I mean, if we pretend it's not depressing to get old, are we not missing the boat in some ways? How can you address the realism of aging?
Yeah, that's a beautiful question. I'm not sure how to answer that. What would you say, Dr. Lewis?
I guess the only thing that we can say is like having the information and kind of knowing that it's like having medical conditions and different limitations can impact your depression. Maybe that can equip you with making sure that you have those strong coping skills earlier on. So if you do happen to experience some depression, you already have the tools needed to fight it. But yes, it can, when you're used to doing certain things and then everything kind of changes, sometimes that can bring on sadness. But if you're already aware that that is a possibility, maybe it can kind of help with how much it impacts your day-to-day.
Well, I think you can look at denial as kind of a double-edged sword. If you can deny certain problems, you might be able to pretend it's an okay situation.
Yeah.
Thanks for the lecture.
Yeah, of course. And thank you for the question and for coming to our presentation.
It must be important as to, in a general sense, how you're physically feeling, because you're lucky. I mean, some people say, considering the alternatives, it's not so bad having reached this stage. But if you're beset by all sorts of physical ailments and other things going on in your life, then it would be easy to see how someone could get um, depressed about that. Phyllis, you have a comment?
Thank you,
Phyllis?
Ken. I have to question the a priori definition of elderly as 65 in the United States. I think it all depends on a person's individual characteristics. I mean, I'm about to turn 80. I just biked 10 miles the day before yesterday. I walk 2.5 miles every morning. Here I am involved in this intellectual exercise. And but to refer to Shirley's comment, yes, seeing oneself age and knowing that there's a limited time available is depressing. I feel trapped. I feel trapped in the process of aging, and I'm not ready for that. And I suspect that's true for a lot of us. So,
I would say listening to your activities, Phyllis, also is somewhat depressing to some of the others of us.
well, I've been doing it. I've kept up.
No, that's the point.
So yeah. Oh, anyway, that's the way it is. But I am wondering about how well geriatricians on the whole, by and large, are trained to deal with depression. Dealing with my mother's situation, she had normal pressure hydrocephalus, which by the time it was diagnosed, she was already in early dementia. She refused to have the usual shunt or stent introduced, and they didn't even, her geriatricians didn't even recognize her dementia because it was frontal temporal. It involved a personality change rather than a loss of memory and so forth that they usually use. So it was very difficult to deal with her and to get the proper treatment for her. Thank you.
I'm sorry that you went through that.
Other questions? Oh, Izzy, sorry.
How is this COVID epidemic impacted on all of this? The restrictions and all the things we have to do now because of COVID, has that amplified depression or created more? Or?
Yeah, so we do know that a lot more individuals have become depressed during the COVID pandemic. The lack of socialization is not a normal thing for humans. And so it has been incredibly difficult for children, for adults, for the elderly. And unfortunately, I don't think that maybe the healthcare system was as prepared to provide as much mental health services to everyone during that time. But yes, it did increase depression.
So, I think you could easily see where decreasing interhuman contact doesn't help. And that's exactly what happened with the lockdowns that were put on for COVID. One of the things that struck me in your epidemiology is that the incidence of depression seemed to be less outside in the rest of the world than it is in the United States. Does that mean that we're have too big a sense of entitlement, or what does that really imply is different?
Yeah, I don't know the answer to that, but yeah.
Ooh,
Final thoughts?
Yeah. Well, you want to make any final comments, Stephanie?
Well, again, I just want to say thank you to everyone who's here and participating and learning more about mood disorders in the elderly. I think this information is important not just for you and for your own benefit, but also for helping your colleagues and your friends. And recognizing, maybe if they're feeling down or if they're not as motivated or as interested, perhaps trying to start a conversation on depression and encourage that they seek some help is really important. Unfortunately, there is a lot of stigma towards mental health, and I think having this conversation and learning about this is just so important to reducing the stigma.
So, thank you. Before we sign off, I just want to alert everybody to the fact that next week we will not have a talk. That's because next Monday is a federal holiday recognizing Dr. King's birthday. So we will continue 2 weeks from today, and we look forward to it. But I'd like to thank Dr. Gerialde very much for her presentation.
Thank you.
And to all the participants, thank you.
Thank you.